For many patients using liraglutide Saxenda, self-injecting may be a first. And there can be a perception that they'll have concerns about injecting and difficulty staying on track. But what we know is this: a little support goes a long way. Start by explaining how liraglutide Saxenda works and tell patients why it must be injected. Then demonstrate the injection process. The best way to do this is to administer the first dose in the office. Don't have time to demonstrate the injection? Refer your patients to the EduCare hotline, a free step-by-step support program that includes patient educators who help with liraglutide Saxenda pen training and overall chronic weight management. You can also tell your patients to download the Motivo app for more holistic weight management content. It's also important to set realistic goals and checkpoints, including a follow-up visit at 12 weeks. This is an important time to evaluate change in body weight and look for at least 5% weight loss. Reaching this benchmark goal helps ensure your patients are on track for continued success with liraglutide Saxenda.
Mabuhay! Welcome to Class 1999's webinar series. Maraming salamat po sa inyong pagdalo. We would also like to thank Class 98 for allowing us to start implementing our homecoming activities 1 year before our Silver Jubilee year in 2024. I hope you will learn a lot from our webinar series and participate in the succeeding events that Class 99 will sponsor leading up to our homecoming in December 2024. Mabuhay po tayong lahat!
About 1 in 3 adults have pre-obesity or obesity, and globally, around 45% of patients go undiagnosed. Why? It could be because there's a perception that obesity is not a disease. But as you know, it is. There are physiological factors at play that could contribute to or cause obesity in your patients. And that's why a clinical diagnosis is important, and hearing it from you matters to them. According to one study, diagnosed patients were more likely to attempt to lose weight. The most common measure for diagnosing obesity is body mass index. To measure BMI, you can use an online calculator, a BMI scale, or the BMI chart. A BMI of above 25 is in the range of obesity, according to the Asia-Pacific classification. Another important measure of diagnosis is waist circumference. This is particularly important because it can indicate a higher risk of cardiometabolic conditions, such as dyslipidemia or hypertension, even if BMI is not greatly increased. To measure waist circumference, wrap a tape measure snugly around your patient's middle section and take the reading after he or she exhales. Men are considered at higher risk at greater than 90 centimeters, women at greater than 80 centimeters. Remember, obesity is a disease, so it's important to treat it like one.
Mabuhay! Welcome to Class 1999's webinar series. Maraming salamat po sa inyong pagdalo. We would also like to thank Class 98 for allowing us to start implementing our homecoming activities 1 year before our Silver Jubilee year in 2024. I hope you will learn a lot from our webinar series and participate in the succeeding events that Class 99 will sponsor leading up to our homecoming in December 2024. Mabuhay po tayong lahat.
As we gather for this webinar, which is part of the UPCM Class of 1999 webinar series, let us acknowledge the source of all wisdom and the creator of life. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Our Father, we come to you grateful for this opportunity to expand our knowledge of the many wonders that you have imbued in the human body. Grant us knowledge and understanding so that we may better use our intelligence to bring healing and comfort to our brothers and sisters who are ill. Grant us humility to treat our patients with compassion and love. We pray also for our presenters. May they share with us their expertise with confidence and kindness. We ask all this through your Son, the Divine Physician, Jesus Christ our Lord. Amen. Sa ngalan ng Ama at ng Anak at ng Espiritu Santo. Amen.
We would like to ask everyone to kindly turn off your microphone and video. Please type your questions in the Q&A chat box. We will try to address all of them in the open forum after the presentation. Evaluation and post-test questions will be available for 1 hour after the initial broadcast. A certificate of attendance will be emailed to you once the evaluation and post-test are completed.
Good afternoon, everyone. I am Dr. Subel Go of the University of the Philippines College of Medicine, class of 1999. I am an internist and a nephrologist, and I am here on behalf of the UP Med Webinars team of the class of 1999. Today's webinar is Class 1999's last webinar for 2023. Our topic is about patient adherence to obesity management. And before we introduce the speaker, we would like to remind the audience that can you type your questions in the chat box even while the lecture is still ongoing. For today's webinar, we are privileged to have a distinguished alumna of the University of the Philippines College of Medicine. Dr. Mia C. Fojas had her residency in internal medicine and fellowship in endocrinology, diabetes, and metabolism. And she is the Clinical Associate Professor of the Section of Endocrinology of the Department of Medicine of the UP-PGH and a Senior Lecturer of the Department of Biochemistry and Molecular Biology of the UP College of Medicine. Dr. Fojas is a past president of the Philippine Association for the Study of Overweight and Obesity and is currently the Honorary Secretary of the Asia-Oceania Association for the Study of Obesity. Ladies and gentlemen, we are proud and honored to welcome my batchmate and dear friend, Dr. Mia C. Fojas of the University of the Philippines College of Medicine, class of 1999.
Thank you, Subil, for that kind introduction. And thank you to Novo Nordisk for this opportunity to talk about this topic and to the UP College of Medicine Class 99. Today, we will be discussing about the importance of adherence to obesity treatment. These are my disclosures. And here is the outline of this discussion. First, we'll be discussing about the challenges in managing obesity, and then medication adherence, and we'll be addressing the adherence in obesity management. For the past several years, there have been great changes in the way we perceive obesity. With the shift in the definition of obesity as a medical disease, the approach to obesity has shifted as well. Although lifestyle management remains as the foundation of managing any chronic disease, pharmacotherapy is now considered as one of the pillars in the management of obesity. This is similar to how we treat other chronic diseases like diabetes or hypertension. In an observational study called the Action IO, a study which looked into the gaps, barriers, and perceptions of both doctors and patients on obesity in terms of weight management conversations, data have shown that only approximately half of all persons with obesity had discussed their weight with a healthcare provider in the last 5 years. From the total number of responders, only 1/3 was diagnosed with obesity, and around 1/5 or 21% were provided with a follow-up appointment or call related to weight after their last visit. This highlights that there is room for improvement in the discussion between healthcare providers regarding initiating weight discussions, as well as improving diagnosis and taking a more active responsibility in weight management for their patients with obesity. This clearly shows that obesity is largely underdiagnosed and grossly undertreated. In another related study called the Action APAC study, which focused more on the gaps, barriers, and misconceptions on obesity within the Asia-Pacific region, we gained the insight that most persons with obesity prefer to lose weight by themselves than rely on medications, and are concerned about the side effects and safety of anti-obesity medications. While 2 in 3 of healthcare physicians or healthcare providers feel that their patients trust them to recommend weight loss medications, such as just as many healthcare providers are concerned about the side effects and long-term safety of the anti-obesity medications. Okay. In terms of utilization, despite the fact that less than a quarter of patients with obesity are treated, 20% of patients are still started on lifestyle management, while only 10% of patients get their benefit of starting pharmacotherapies for obesity. You can see that in this cartoon, this slide. And to add insult to injury, considering the very low initiation of pharmacotherapy, we also learned that adherence to anti-obesity medications are likewise very low. In this slide, you can see that considering the different medications available, this is liraglutide, this is phentermine with topiramate, and naltrexone with glutathione, and leucoxetine. Considering these medications that are available with the currently leading anti-obesity medication, which is liraglutide, the only injectable therapy among the available anti-obesity medication, only half of patients persist on treatment at the end of 15 months. So what is the impact of low adherence to treatment? What we know from this meta-analysis is that regardless of intervention, whether it's lifestyle modification or with other modalities, including behavioral therapy and surgery, during a particular intervention done, weight regain is expected as soon as the intervention is stopped. You can see that everyone, para siyang Nike check mark. Anyway, this shows that weight loss following lifestyle intervention is not sustainable in the long term. Most individuals regain more than half of their weight within 2 to 5 years. And why is it recommended to incorporate pharmacotherapy as standard of care for obesity management. And you can see that long-term pharmacotherapy is an integral part of obesity management. And the new generation of anti-obesity medications can actually maximize the magnitude of weight loss, help to overcome the compensatory mechanisms that induce weight regain, promoting sustained weight loss. And you can see this placebo effect and this pharmacotherapeutic effect, and where there is 15.2% body weight change with addition of pharmacotherapy. Now, let us talk about medication adherence, the concepts, definition, and taxonomy. Adherence is definitely key to therapeutic success in any kind of treatment of any chronic illness. So you have your effective therapies, effective disease prevention and management. Adherence to medications is very important in the middle. But again, as Dr. Everett Koop mentioned, drugs don't work in patients who do not take them. Let us now talk about the ABC taxonomy, medication adherence. This was a project that was started as a first work package of the funded project in Europe, ascertaining barriers for compliance, policies for safe, effective, and cost-effective use of medicines in Europe. But a part of that is the taxonomy for describing and defining adherence to medication. And this was presented initially by the European Society for Patient Adherence, or the ESPACOMP. ABCs in the medication taxonomy or medication adherence is a process by which patients take their medications as prescribed. First part would be initiation, implementation, and persistence. And you can see here that if despite the advice, if the patient does not initiate treatment, so that's a barrier. And then implementation, the patient may delay or omit or takes extra doses of the medication. That's a dosing history. And patient may actually discontinue treatment. So that is a problem with persistence. There are different forms of non-adherence. Now here, you can see that 20 to 30% do not initiate new prescriptions based on the study published in 2018. So here, another problem with non-adherence is the implementation. Daily, 15% do not implement treatment as prescribed. And persistence, 40% of patients discontinue treatment within the first year. So you can see again that here, for the initiation, if the patient does not take the medications, of course, drugs won't work among patients who do not initiate them. For the implementation, drugs work partially or may create harm among patients who implement a dosing regimen sporadically. And this has been a problem with our patients being treated for tuberculosis before. And persistence, drugs definitely would stop working among patients who discontinue them. And you can see here the drugs forgiveness. Forgiveness is defined as the difference between the medications post-dose duration of beneficial action and the prescribed dosing interval. In plain words, it directly relates to the number of doses that can be skipped without causing detectable disease relapse. Forgiveness arises by two major mechanisms, and you're familiar with these things: prolonged inhibitory effect of the drug on its target, or the pharmacodynamics, and or the prolonged half-life of the drug at the site of action, or its pharmacokinetics. Now, adherence is key to avoid treatment escalation and needless combination therapy. So if you have suboptimal adherence, there can be treatment failure, there can be disease progression, or an acute event can happen, and more complex treatments might be needed to actually treat the disease. And again, with more complex therapies, there may be more suboptimal adherence. So this is a very vicious cycle. So what is the state of things with regard to medication adherence in chronic disease? The adherence determinants are multifactorial, and more than 700 factors were identified associated with non-adherence. And these are the different factors. The 700 factors were divided into these 5: patient factors, healthcare provider factors, socioeconomic factors, therapy, and condition. Moving on. So take-home message based on the statement of the World Health Organization is that poor adherence to treatment of chronic diseases is a worldwide problem of striking magnitude. Adherence to long-term therapy for chronic illnesses in developed countries only averages about 50%. So we need more action with regard to this. And here are some of the facts and figures. Again, increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatments. And that was a problem with some of the infectious diseases as well, not just in obesity. Again, 50% of medications for chronic diseases are not taken as prescribed. This is a statement from the WHO. And in a published study by New England Journal of Medicine, costing of the U.S. healthcare system has increased from 100 billion US dollars to 290, and 20,000 deaths in Europe was due to non-adherence, and this was 20,000 of hospitalizations in Belgium were due to incorrect use of medications. This was as of 2012. Now, let's talk about the anti-obesity medications. What are the enablers for adherence? For the patient-related factors, if the patient knows, are aware, or the patients are aware of their higher baseline BMI, aged 30 to 50 years, and female sex, that these have been studied very well on based on cohort data. And some healthcare provider related factors, those who are more involved with their patients' treatments, and these are the modifiable factors. And also condition related factors, the comorbidities are non-modifiable factors. Supervision is very important as well, and this is modifiable. Therapy related factors would be knowledge and treatment outcomes, perception of the risk-benefit ratio, treatment duration, and number and type of anti-obesity medications. These are very important. Now, what are the disablers for adherence? These are the following. For the patient-related factors, it's low socioeconomic status, and this is non-modifiable, possibly modifiable depending on the economic situation. Misbelief and misconceptions, concerns on treatment and outcomes. Healthcare physician provider related factors would be the lack of knowledge, irregular follow-ups. Condition related factors would be stigma, depression, poor health conditions. And therapy related factors would be your complex treatment regimens, duration of treatment, low drug tolerability, adverse effects of the treatment, and slower onset of visible outcomes, and costs and lack of reimbursement, which actually is here in the Philippines. It's one of those conditions. Now, if we now look back into the ABC taxonomy of adherence and relate this with the more than 700 factors, you can see here that in initiation, there's a patient's lack of insight into the illness, patient's lack of belief in the benefit of the treatment, and patient's concerns about the medication and the cost. And forgetfulness in implementation, complexity of treatment, presence of cognitive impairment, possible alcohol abuse, family conflict or disorganization. Persistence would be the non-adherence would be side effects. Poor provider and patient relationship, missed appointments, and previous behaviors and experiences. Again, medication adherence is very complex and it's a multifaceted problem. So here you can see just the iceberg, and below the iceberg, there are more factors related to non-adherence. And this has been recognized by the World Health Organization as well. Now let us move on to the search of a magic pill for medication. That is it's magic. So medyo right now it's impossible. There's not one solution, but many. Each solution may work, but end personalization is key nowadays. So hindi siya dekahon ang treatment for any chronic illness. So you have to really talk to the patient. So investing in medical adherence improves health outcomes and health system efficiency. These are the important factors that we have to know, acknowledge, incentivize, inform, steer, and support. Acknowledge that medication non-adherence harms health and increases harms health and increases healthcare costs. We need to incentivize, change financial incentives for providers and patients, inform, systemically monitor adherence as a performance indicator, and multidisciplinary involvement of all stakeholders to address the problem that only 50% of patients can adhere to the medications that are prescribed. And this is one of the most important ones, the steer and support stuff. So adherence process begins with a patient and a prescribing clinician and a dispensing pharmacist. So measuring adherence is also key to managing adherence. However, based on previous data, this only happens mostly in research when we do the pill counting. So we need to actually address patient adherence in our clinics as well. So to conclude regarding the patient adherence, problem is poor adherence to treatments for chronic diseases is a long neglected worldwide problem of striking magnitude. Its consequences are based on biased clinical study results, poor outcomes of drug treatments, emergence of drug resistance, and added costs of healthcare. The opportunities would come in the advent of uniquely powerful medicines and reliable means to measure adherence, bringing patient non-adherence into clear view. Achieving satisfactory adherence may have greater impact than any other maneuver to improve medical treatments. And we need to act. Health systems must evolve to meet the challenge of achieving satisfactory adherence to therapeutic drug regimens. Patient-tailored and measurement-guided intervention are required to achieve sufficient adherence to therapeutic drug regimens. Now, let us move on again to anti-obesity medications. So what do we know about adherence to anti-obesity medications? This is a population-based cohort study that used claims data from commercial health insurance in the United States. Patients initiating an anti-obesity drug between 2004 and 2018 were included. Trends in the utilization of anti-obesity medications were plotted by year as a proportion of any anti-obesity medication treatment and as initiation rates per 100,000. The results show that the use of anti-obesity drugs was very low at 2 initiators per 100,000 individuals on the average, despite its increase in recent years from 1.3 initiators per 100,000 in 2004 to 2.5 initiators per 100,000 in 2018. In addition, the utilization of liraglutide, you can see that, where's Saxenda here, 2015. Liraglutide 3 milligrams is increased over time from less than 10% in 2015 to over 20% in 2018. The average age of initiators was 45 years old and above, and slow initiation was mainly due to lack of awareness among primary care physicians and cost-related and previous experiences with anti-obesity medications. So you can see that in this. So in another population-based analysis, here you can see that first-time medication users. This is based on a HMO pharmacy in Israel that included all men and women aged 21 years and older who were HMO members during 2003 and 2007. The average duration of therapy was just 2.1 months for orlistat and 2.9 months for sibutramine. Fewer than 2% completed 12 months of weight loss medication treatment, and annual weight loss drug users, high body mass index, and you can see those were the ones included in these population-based study. So these are the drivers for low persistence rates. So adverse events, slower onset of treatment effect, cause of treatment, and absence of comorbidities, and lower BMI at 35 kilograms per meter square. Now, what are the determinants for adherence for the anti-obesity medications? And you can see this is based on another population-based study. So you can see that it's almost the same as the earlier slide, right? So, and disablers, again, low socioeconomic status. So it's the same. So what drives stay time with anti-obesity medications? First, patients whose healthcare providers would set appropriate expectations about the AOM experience and time on the AOM, stay on their medication longer. So it's very important for us healthcare providers, to orient our patients and set realistic goals. Patient confidence, motivation, and prioritization of health are key drivers to stay time. Lack of understanding around the chronic nature of obesity and health prioritization correlates with shorter stay time. So it's important that we have more important priorities, prioritize the chronic nature of obesity and not just the aesthetics. Cost, side effects, and lack of efficacy are definitely barriers impacting stay time. Previous experience with AOMs and over-the-counter medications lead to shorter stay time as well. The strength of relationship with their healthcare providers has a positive influence on patients' stay time. And other supporting weight loss efforts help to increase the patient's stay time. And that is my last slide. I hope we helped those healthcare providers actually managing obesity.
Thank you, Dr. Folhas, for that very comprehensive talk. At this point, we'd like to thank our sponsor, Novo Nordisk. The floor is now open for questions from the audience. Please type in your questions in the Q&A box in the lower edge of the Zoom screen or in the comments section for viewers of Facebook Live and UP Manila live stream. I think I see a question come up, Mia. Let's start with that for now. I guess some of the attendees still want to talk about the certain causes of obesity. I think the highlight of your talk today is more about adherence to management. Apart from medical therapy, I would like to see if you also talk to them extensively about diet management, perhaps, along with the medication you prescribe.
Yes, actually, yun yung pampatagal ng consultation bawat pasyente. However, luckily, there's a program now for those who are on GLP-1s that we work together with nutritionists and dietitians to fix or kasi hindi naman dekahon ng diet, no? So, merong particular number of calories per body weight and per sex or gender. So that's how we do it. So personalized medicine is very difficult to do and it's very lengthy. That's why we need specialties handling this one. So meron kaming team.
That's exactly what I wanted to hear. I think a lot of time as healthcare providers, other than our ability to prescribe, we actually have to tell the patient what the game plan is. And we also have to emphasize all the pharmacologic and non-pharmacologic options. I think some people are asking about certain kinds of diet more than anything. I'm sure there's many different fad diets that come with this management, keto, South Beach, what have you. But I think you probably take into consideration all the patient's requests along with medication management. How do you deal with explaining to the patient about side effects? Once they start feeling the gastrointestinal side effects of a lot of these anti-obesity medications, how do you convince them to stay on board with treatment?
The warning is key. So before you even prescribe the medication, you actually tell them the side effects that will be expected. Occasionally, these patients hindi nila sinesettle sa brain nila. Kaya later on, and they go to the ER feeling the reflux symptoms. But then again, that has been warning prior to the prescription of the medication. Like I tell them, okay, since this slows down the gastric emptying time, try to stay away from fatty and spicy food. And this is short of doing bariatric or sleeve gastrectomy, so parang lumiliit ang capacity ng tiyan nyo. So hindi ka pwedeng sobrang magpabusog. Otherwise, you'll have nausea and vomiting. So they have been warned prior to the prescription. But for those who did not really listen well to the warning, so I just reiterate, so we have to prioritize. For example, some of the patients kasi they had already symptoms of reflux because of several illnesses like diabetes and all. So medyo hindi mo na siya pwedeng ma-continue. So you try to shift to other means aside from you stay away from GLP-1s, but you still encourage lifestyle modification, and maybe later on pag medyo maganda na yung galaw ng tiyan nila for those, especially with diabetic autonomic neuropathies. So, yon, baka pwede mo ng low dose i-resume.
How do you feel about the patients when they come and see you? Because you're an obesity specialist, so do they come with a preconceived notion that they're seeing you to get a prescription, or do they mostly come to see you to get advice other than medications?
Yeah, very good question. So a lot of them can afford the prescription. So they actually come in for the prescription. But of course, there are also warnings, no? So hindi yung expectations, you have to tell them na hindi tayo sa ganda, kasi a lot of these individuals would consult you not for health reasons. It's really for aesthetics. So some patients do not have that indication. So you have to tell them that, there are certain parameters wherein you have to give medications. Otherwise, you can just have to settle with lifestyle modification. Because merong mga pasyenteng mas nangangailangan kesa sa kanila. And like right now, there's a limitation sa supply ng gamot.
Yes. Do you feel that patients are happy to stay on the medications when it's prescribed in general, or do you have some who will tell you that I'd like to do other things, like maybe consider bariatric surgery instead of medications?
Rare that bariatric surgery, they'd rather stick to the
Okay.
medications because the bariatric surgery, remember, culturally, no? So parang it's for them, it's really not a normal thing. So physiologically, it's maraming gagawin sa tiyan. So parang a lot of people are definitely scared of surgery, period. Lalo na for those individuals na parang they feel, wala naman ako masyadong sakit to undergo this. However, mas maraming nagsistay on sa gamot. However, only up to a certain point. Like if they already achieved their target weight. So they ask if they can, injectable kasi mostly, if the medication can be removed. I tell them we can try. However, there's still that chance that there might be weight regain. But they say that they already had the lifestyle modification and they have learned a lot. Some patients come back for represcription kasi na-realize nila, oh no, parang bumabalik talaga. Kasi again, the set point, bumabalik Bumabalik siya sa, meron sa hedonic and homeostasis, no? So yun ang mahirap na i-control. So yung iba nagpapa-represcribe, yung iba for as long as they continue with their lifestyle modification and develop more muscles, especially among females, no? Mas madali nilang nababurn yung calories.
I guess some patients are also wondering which one is the best medication. I think that's a very difficult answer.
Yeah,
Very
wag na. Wag na.
I,
Appropriate medication siguro for you kasi hindi yan dekahon.
I saw this interesting question about your thoughts on diet pills available online. Safe ba yun?
Nakakatakot naman. Wala tayong enough budget for liver transplant at walang namimigay ng atay sa matatanda. Usually sa babies lang. So mahirap, no? These are not regulated online. Most of them are not. And we do not even know if these are tampered.
Do you have patients who also inquire about herbal approaches, remedies when in discussion with the anti-obesity management?
Yeah, and the most common would be those that contain seaweeds. So it's because yun yung mga it increases supposedly the thyroid hormone. It increases the metabolic rate, but this is very dangerous. And these are incorporated in some pills that are online na hindi mo malaman kung gaano kataas ang dose. And of course, these are not regulated, no randomized controlled trials, so you do not know the safety and efficacy. Occasionally, they would have weight loss, but then again, meron ding isa noong araw, merong nag-advertise, it's a derivative of green tea because it's really thermogenesis, no? It increases metabolic rate, ganon. But apparently, yung iba bumababa ang white cell count. So it's dangerous. Tumababa ang white cell count, tapos tumataas ang transaminases. So we have to be careful.
I guess there's probably increasing awareness for the use of either semaglutide or liraglutide for obesity because there are some questions asking about, is it effective for use in obesity? And I think your slides previously did say that they are effective, and there's lots of clinical trials that prove the effectiveness of these kinds of medications. Let's see. Oh, this is a good one. So what happens when you stop your medications after you've achieved your ideal BMI?
Yan. Yun nga yung sinasabi natin, yung parang Nike effect, no? They actually, most of the patients do have weight regain. But in my experience, because I actually tell them that they can have weight regain if we stop. So they monitor themselves. They're more proactive with regard to their diet, lifestyle modification, and some oral medications, especially for those who have diabetes. So when they do regain, it's not at the baseline level. So that happens when you stop, pero a lot of patients who do not really, who just rely on the medication, without lifestyle, medyo nagre-rebound talaga sila when you stop.
How often is cost a factor in your treatment of patients? So although there are certain medications that have come out recently, and I don't think it's appropriate for everyone because I think you have to tailor your recommendation depending on what's available to them, to their budget.
So it's very expensive. So per pen is about 7,000 pesos, and it's not just one pen a month, it's about 5 pens in a month, depending on the dosage for the patient. So it depends on what obesity class and stage you are in. So it's quite expensive. It's not gonna cost you less than 15,000 pesos a month. So it's very important.
Do some patients come into you thinking that after they take one dose of this medicine that it's supposed to cure everything?
Yes, oh my God. Yun yung medyo Natawa nga ako kasi nagkamali ako sa prescription na this is the maintenance dose. So when you titrate the dose up to this point, period. So nung na-titrate niya na to the maximum dose, the optimal dose, ni-stop niya kasi na-reach niya na. Naloka ako ng slight. So sabi ko, you have to continue the dosage. Hindi yun nisa-stop doon. Nakakatawa. Pero yeah, merong ganon, nisa-stop nila. Akala nila yung parang, ay, hindi nag-work. Kasi
Okay.
na-reach ko na hindi ko pa rin. No, but it takes about 12 weeks for you to at least judge if you lost 5% of your baseline weight. And that's the success. That's supposed to be the minimum success rate of the medication that's given to you.
At least that's a good tangible target when you say 5%. So at least people can calculate, people can see. I think it's always hard to convince someone to tell them continue because you're doing well. Once they tell you I cannot take it anymore because of the side effect or it just costs too much. So I think you're doing a great job in increasing awareness that obesity is a chronic illness. It needs long-term solutions, long-term medications, and long-term adherence to therapy. So I think
And I guess Sub's corollary to that, no. So what we have been pushing for is that obesity is the root cause of a lot of other illnesses like hypertension, diabetes, polycystic. Oh no, it's not the root cause. But if you manage obesity, mas magaganda yung kanilang hormonal profile, obstructive sleep apnea, osteoarthritis. So that's what we are pushing for. You manage obesity to lessen the medications for these other comorbidities or chronic illnesses.
So is there generally a good awareness now that people realize that obesity is an actual disease, just like hypertension is a disease?
Well, here in the Philippines, at least, some people actually consult for obesity alone, and the more aware ones are aware that the more aware ones would consult so that their medications can be tapered off. Right now, there is that thing na obesity is a disease, and more consultations happened after the declaration that it is one of those chronic illnesses, especially during the pandemic, no, during the vaccination prioritization for people who are obese. So mas naging aware sila.
At saka there's a reminder pala to kind of redefine what obesity means so that we have a ground level understanding of who needs to see a physician, because
Yes.
I think we need to be clear about who we're talking about. That is obesity overweight. Is that the same thing, Mia?
So here, no, in the Philippines, kasi iba yung iba-iba per region. So here we have obesity defined as a body mass index of 25. I believe that in other countries there, sa US na 30 yata, 25 dito. So there is that awareness. But yung 23 to 24.9 na pre-obese or overweight, pre-obese yung pinupush na ibang term eh. Yung pre-obese, may risk factors naman sila, but we do lifestyle modification, not really so much of the pharmacotherapy unless there are comorbidities.
Is there a push for your society to educate people more that this is not a symptom but rather a disease itself? Like,
Oh, definitely.
I think a lot of our co-healthcare workers, even RNs, physical therapists, I think there's also there's a good yield for us to reach out to them and make them realize that obesity is a disease itself,
Yeah.
and there are specialists for this. And so I think you guys are doing a good outreach by having this obesity and overweight fellowship.
Hindi naman, kasama siya sa endocrinology. However, the Philippine Association for the Study of Overweight and Obesity always has this regional project na ang dami actually naming allied medical professionals na nagjo-join sa aming mga activities, and because obesity is supposed to be managed by a primary healthcare physician and together with other allied professional. So, hindi pwedeng kasing mag-isa lang. So, we have been going from different regions. Dati kasi, when we had more budget, meron kaming Luzon, Visayas, or Mindanao. Ngayon, hindi na masyado, no? So, merong siguro once a year. Not sure if we will be pushing for Zoom, but at least yung mga postgrads and webinars, we are being helped by other non-government organizations as well.
Even just as a kidney specialist myself, I don't normally manage obesity and overweight. I do see the complications of it, so I'm highly appreciative of how the availability of these current medications have reduced the progression of kidney disease. So I think
Talaga.
your
Galing.
specialty ties in very nicely to my specialty because the outcomes that we look at are very similar to yours, like a
I
proteinuria,
know.
hypertension control. So I think obesity is now something that's already a diagnosis in itself, but it also sets a target for us that we can try to fix that. Whether
Diba?
it,
We've gone a long way, no? Since residency, Subil.
yeah,
Grabe.
I think,
Anyway.
yeah, I think obesity is not just mataba. I think we have to steer
Yes.
away from the preconceived notion that you're mataba, and if you're mataba,
Mm.
it's okay because you could still be healthy and mataba. So I
Yung
think
MHO. So we have to also focus on the visceral fat. Yun nga yung sinasabi namin na parang, huy, hindi porke okay ang body mass index mo, hindi ka na obese kasi there's such a thing as visceral fat, no? So meron ding waist circumference, waist height ratio, and waist hip circumference. Kasi usually BMI would underestimate obesity among Filipinos especially. So, kasi tayo yung thin outside but fat inside. That's why we are trying to get into other means of to measure obesity for our fellow men here. So, medyo mas mahirap kasi sa Asians.
marami rin nagtatanong about mga specific diets. So I think it's more individualized, like wheatgrass, oat milk. Uh, I think that's probably uh, a little bit out of the scope of this talk today. I think a lot of people are really very invested in changing lifestyle, and I congratulate everyone for having the curiosity of how to spearhead their lifestyle modification. But there's a pervasive topic here that keeps popping up about how obesity and hormonal diseases tie in together, like PCOS, and things like this. I think it would be good for you to weigh in on hormonal issues
Mm-mm.
relating with obesity or diseases
Well, it
with.
is known that among females, no, estrogen is very protective. So when you reach like perimenopause and menopausal stages, so medyo nagkakaroon ng more visceral fat deposition. So again, we are at a higher risk if estrogen goes down. So maybe in a lot of cases, one should consider checking their hormones out when they are in the perimenopausal stage. In the same manner, sa polycystic ovary syndrome, no? It's not really so much of the chicken or the egg if it's obesity causing the PCOS or PCOS causing the obesity. It's not really like that. It's that among PCOS patients, they have more visceral fat. So you have to manage also obesity aside from the hormonal problems that they have. But occasionally, for some PCOS patients, when you manage obesity alone, the hormonal problem will be more regulated, but they still have that risk of developing diabetes later on, the fact that they have PCOS. So you still have to monitor and regulate their menses and check the PCOS situation and hormonal situation of that individual.
Perfect. I guess there are some people who are now interested in joining your specialty. There are some physicians, it looks like they're asking if there's a special field offered to physicians wanting to train in obesity management.
For now, no, wala pa kaming ginagawang ganon. However, that's what we are doing is that we have a module on obesity management with PASOO. And meron kasing we have been working with the World Obesity Federation on this. I'm just not so sure kung anong stage na kasi past president ako ngayon. But we'll try to please check out our PASOO website, obesity.org.ph for more information. And I think we have Facebook page as well.
Meron din nagpapa-clarify ulit ng obesity diagnosis if it's greater than 30 BMI.
No, it's not. Kung Filipino tayo, it's 25 ang BMI natin. Tapos 23 to 24.9 ang overweight or pre-obese. It's 25. Sa Singapore and Malaysia, it's 27.5 ang cutoff nila. So, magkakaiba sa mga Asian region. Sa Brunei, 30 talaga ang cutoff kasi yun yung nasa-shoulder din ng kanilang government. So, there, 25 talaga. But as for the waist circumference, iisa, 80 centimeters for females and 90 centimeters for males, at least for the South and Southeast Asian regions.
So may special, that's news to me actually. I wasn't aware that there were different standards set by different countries on the diagnosis because I thought because it's ICD code for obesity, so I thought obesity meant established BMI across,
Yeah,
just like
oo nga.
it tends to be
Napansin
standardized
ko yan.
across.
Oo. Kaya nga dyan sa
Oh,
US, kawawa yung mga
kayo
Pinoy
yung-
na obese. Hindi
Ikaw
sila
yung
naniniwala.
nag-introduce niyan sa society ninyo na baguhin yung BMI diagnosis sa
Walang
Pilipinas.
iya, hindi. No, may studies naman yun. Grabe.
Like, it's interesting. I guess if you hadn't spoken up earlier, I wouldn't even have known that the definition differs just from country to country. This is the first time hearing of it. What do you feel about people seeing you just to avoid body shaming?
Hey, wala na. Alam mo, we have to do a study on that, no? Kasi yung fat stigma, mas common kasi yan. So, Bill, I'm sorry, mas common siya sa Chinese community. Yung fat shaming, grabe, like even in Singapore. But here in the Philippines, we have to do a study on that if it's prevalent. Kasi parang iba eh. Our culture is like pag bigger, like in children, pediatrics, di ba? Parang if the child is bigger, that's healthier. So for adults, I'm not so sure if it happens. But I think doon sa APAC, Asia Pacific na na action, 'di ba? May action APAC. Online kasi yung kanilang survey. So merong mga hindi na i-employ because they are bigger. Oo, mataas ang BMI nila. Tapos yung iba parang more depression. So meron siguro, but we have, that's maliit lang ang number ng mga Pilipino na na-include doon. So I guess we have to do a bigger study here.
So anecdotally, would you say that there are some people who see you in your office saying, I need to be a certain weight
Yes.
for me
Yes.
to get a job or to get promoted or to be a stewardess or...
FAs ang pinaka-common. Flight attendants, yes.
Okay, I see. Oh, I guess we have time for one last question. So overall, I think we've covered a lot of ground, actually. I was surprised. The back and forth was pretty brisk. So what is your, I guess I'll just leave this for you to say, like, what's your final message for people listening about obesity in general?
Again, nako, this is not my first obesity webinar, so I will reiterate. Obesity is a disease, and once you manage obesity, a lot of chronic illnesses will be improved. So actually, your medications can go, the number of medications can go down, especially among those with diabetes and hypertension, just by managing obesity. And obesity does not just involve lifestyle modification. Please consult your doctors if there are appropriate medications to be given to you. So, and that's it.
Thank you for all the questions from the audience, and thank you, Dr. Mia Fojas, for enlightening us with your answers. Although we have more questions in the Q&A box, unfortunately, we are unable to get to all of the questions. We apologize to all the viewers whom we could not get to accommodate during our 1-hour session. In summary, personally, my personal summary is what we've learned from today's webinar is that number one, obesity is a chronic illness. And secondly, obesity requires a paradigm shift into managing obesity as a chronic illness, not just a physical appearance. I think there's plenty of opportunities for us to make medications accessible to all, of all budgets and all abilities to pay. And I think it's important to emphasize that obesity is a disease, and diseases can relapse if you do not follow through with your management and seeing your physician in a timely fashion. So thank you to our speaker for taking time out of her very busy schedule and sharing her expertise with us today. As a sign of our gratitude, we would like to present the Certificate of Appreciation to Dr. Mia C. Fojas. Thank you very much, Mia.
Thank you, Rinsu, Bill, and nice to see you here. And thank you so much to all the attendees online in Facebook and in Zoom. Thank you so much for listening to us.
We would like to thank the UP College of Medicine, the Postgraduate Institute of Medicine, the UP Medical Alumni Society, and the UP Manila Information Management Service for their support of this webinar service. And again, thank you to our sponsor, Novo Nordisk. This is the last webinar of Class 99 for this year. Thank you very much to all our participants. We will be restarting the Class 99 UP Med webinar series for 2024 in January.
Maraming salamat.
So before we proceed to the evaluation links, let us welcome our Class of 1999 President, the esteemed Dr. Carlo A. Panelo, to close our 2023 webinar series.
Maraming salamat po sa inyong pagtangkilik sa aming webinar series na pinamagatang Bridging Gaps. Alay po sa inyo ng Class of 1999. We look forward to seeing you in 2024 for our homecoming year. Maraming salamat po uli sa inyong pagtangkilik at shout out po sa aming webinars committee na pinangungunahan ni Dr. Mel Cespedes Cruz. Maraming salamat.
Thank you very much, Carlo, for your closing remarks. And again, thank you to our participants who have been attending our webinars this year. We hope to see you again in January 2024. Lastly, for those who want to get a certificate of attendance for today's webinar, kindly answer the evaluation form and post-test within the next hour. You can access the link through the QR code posted on the slide or use the URL posted in the chat box. Thank you very much to all our attendees.
About 1 in 3 adults have pre-obesity or obesity, and globally, around 45% of patients go undiagnosed. Why? It could be because there's a perception that obesity is not a disease. But as you know, it is. There are physiological factors at play that could contribute to obesity in your patients. And that's why a clinical diagnosis is important, and hearing it from you matters to them. According to one study, diagnosed patients were more likely to attempt to lose weight. The most common measure for diagnosing obesity is body mass index. To measure BMI, you can use an online calculator, a BMI scale, or the BMI chart. A BMI of above 25 is in the range of obesity, according to the Asia-Pacific classification. Another important measure of diagnosis is waist circumference. This is particularly important because it can indicate a higher risk of cardiometabolic conditions, such as dyslipidemia or hypertension, even if BMI is not greatly increased. To measure waist circumference, wrap a tape measure snugly around your patient's middle section and take the reading after he or she exhales. Men are considered at higher risk at greater than 90 centimeters, women at greater than 80 centimeters. Remember, obesity is a disease, so it's important to treat it like one.